Nice to talk with you.
Nice to talk with you as well. How are you doing?
Good. I'm really in Pittsburgh, North Carolina, and you told me that you're not going to photograph me, so I'm very relaxed here.
Perfect, perfect. Okay, so I just want to run through kind of an overview on how COVID-19 has impacted you, your institution, and I want to kind of specifically talk about the impact on the elderly population, if that's okay.
Right. So, well, North Carolina, it's very unpredictable, where we'll be. So far, we've not been overwhelmed with patients in the state, but starting to creep up, and there's all kinds of experts and predictions, but my own bias is it's so unpredictable. We don't know. We're pretty well prepared. How it's affected our general oncology population is like all over the country. We're really minimizing face-to-face visits and visits to the hospital. Before we did this, I just was on a 1-hour phone visit with a new patient visit with an older patient. We're trying to do as much we can from home. You miss the face-to-face. There's something about being in the same room and certainly examining patients. Many patients don't really need an exam, but many do. So we're dealing with it. I think our hospital and medical care system has done a great job. Our oncology group, we're all working hard, trying to minimize any of us going in. Because I'm an older doc, my partners have put me on the second tier to go in if I don't have to, or the third tier, which is very generous of them. I'm perfectly willing to go in, but these are some of the rules that have been made. So we're doing fine. We're seeing leukemia. We're doing breast surgery as we can. And the older patients, we're trying to manage them as well as the younger patients. I think there's doing it on a phone, and we're trying to set up these Zoom visits, but we've got such a bureaucracy in America that instead of doing like we do and setting it up with a patient, we have to go through HIPAA in our hospital, which has been problematic. But I'm a pretty open guy, and I ask, do you have Skype or FaceTime? And I'm happy to do a visit with them if the patient is comfortable. Because I think it means so much more face-to-face. And if I do that, I don't have this background and I put a tie on. The older patients in this, I think will fare reasonably well. Many, I think they have a greater fear, obviously, of coming to the hospital. I heard it from this last patient. So when you look at the national data and mortality statistics, it's clear that older people, more comorbidities, cancer or not, are faring more poorly. We don't have great data yet to know who in the older people. Is it just someone 70 with no comorbidities, or do most of the older people who are succumbing have more comorbidities, such, when I say coexisting illnesses, such as diabetes or certainly COPD or heavy smokers, where they're not going to tolerate any infection, including the flu. So we've had thousands of deaths in the United States this year from flu, which is preventable, which we forget here. And it's the same vulnerable group of older people, people in nursing homes, etc. As far as, ironically, a lot of the things we used to do for older people, we're doing for younger people. So for instance, a lot of our new breast cancer diagnoses, because it's hard to set up surgery now, it's hard to have it staffed and everything. What we're doing is, if it's let's say, not a hormone receptor positive, HER2 negative cancer, which is the most common types of breast cancer. I don't know if I'm being too detailed here. But those patients frequently, there's excellent data, can be managed by preoperative hormone blocking therapy, drugs like tamoxifen or aromatase inhibitors. And in fact, they do very well, and it can control them for months to years So for a lot of those patients, especially the older patients, we're temporizing on surgery. It might not be appropriate for a younger patient, a premenopausal patient, but for many postmenopausal and older patients, such a strategy is good. We can manage it at home. The toxicity is minimal. There's excellent database. And then they can have their surgery later on. And in fact, if they had a larger tumor, it may shrink it and make them more amenable to breast conservation. So that strategy we're moving down because we don't want to bring someone 52 in who's got diabetes, and who might be at risk for elective surgery when we can do this. As far as I'm trying to minimize all older visits. If they need a mammogram or a bone density, I'm putting them off. In the United States, we tend to do mammograms yearly, but we know in Europe and other places, they've done studies to show every 2 years this is good. Our population is fixed yearly. And a lot of my older patients, I don't even do mammograms. I do physical exams. They're 75 and 80. So with those patients, ironically, if this is really protracted, we might want to arrange for them to go in for a mammogram, because one of the problems with older people is if they have a shorter life expectancy and it's inappropriate for a screening mammogram, even after a breast cancer diagnosis, is you need to do a breast exam. It's not like they should be floating in space. And unfortunately, in this country, in this culture, we're doing less physical exams than ever. And this epidemic may actually underscore that, right? Because we're doing so much by phone. But there is a value to that. So for some of those patients, if it's a prolonged delay, we might want to consider a mammogram in the local community. But there's no pressing need to do it. If they're feeling well and they're otherwise healthy, to just wait it out until this is over and have them come in. We're monitoring medications over the phone, setting up some video visits. So I think the older people are doing well. Those on chemo, I have some of those. I'm managing like with FaceTimes or Skype visits when they come in the clinic. I'm calling them a day before. My nurse partners and we're very on top of the game here in monitoring those patients very closely. I have partners in there if they're sick. They're in our infusion center, which is giving a lot of chemotherapy. There's nurse practitioners that can check these patients if they're sick as well. Let me just see. Yeah, so I think we've got a very good strategy, a very good plan for the older people, but they're petrified, a lot of them, about coming in the hospital, and I can't blame them. So I've done a lot of talking.
No, that's okay. That's great. Yeah, you hit on a lot of my questions, so I'm just going to run through a couple of them if you've got anything to add.
Sure.
So let me just see. So you talked a lot about, the role of surgery kind of changing. What about like in terms of scheduling and for chemotherapy, immunotherapy, are you trying to space them out more and have people maybe not come into the clinic as much, or is it kind of staying the same?
It's kind of staying the same. I think when you space out things, part of my career was spent learning from great colleagues and mentors like Larry Norton about dose-dense chemotherapy, et cetera. And we know that it has a survival advantage, including a very good meta-analysis. So I think spacing out chemotherapy when it's given for curative intent in the adjuvant setting isn't the best strategy, and we're not doing that. And I don't think across the country we're doing that. Now, if you have patients with metastatic cancer and they're getting an every three-week regimen and they're doing well, and your hospital can't handle the volume, a lot of our nurses are being put on other units and things. We just this morning, our division leadership went over a plan. What's going to happen if our docs, our cancer specialists, get pulled into doing internal medicine, because we're all internists? So I think that I think that we're kind of prepared, but delaying things like chemotherapy, If it's for curative intent, we're going on as usual. Immunotherapy in breast cancer, it's kind of coming in a little bit, like in the preoperative therapy with pembrolizumab and in the metastatic setting with atezolizumab, mainly for triple negative breast cancers. And, you know, I have no idea how they affect your COVID response. You know, when people are dying of COVID, I haven't seen enough good science, but a lot of them get what's called cytokine release and other things. And some of that, or they may have too good an immune system, you know, that overwhelms their own body. So I don't know enough of the science to know how devastating that is. But anything we can avoid now, we don't want to find out the hard way, we're doing. I think it's more of a problem for my colleagues treating melanoma and other things. So for the breast cancer patients, we've been going on as usual with their immunotherapy if they're metastatic, triple negative. Our clinical trials entries have woefully dropped unless there's studies that directly offer the patient some needed therapy that they couldn't get otherwise, which I think is the ethical thing to do. But if it's drug A versus A plus B and B is not a proven value, a lot of the big randomized trials, especially a lot of the big NDA and very well designed and important pharma trials, we're just not doing them now. But if it's a phase 2 trial of a drug on someone progressing with their HER2 positive breast cancer, and we have it where we've made a policy to try to open that and do it as best we can. It's complicated, and someone needs to see those people. But I've done a lot of consents and walkthroughs at home and to try to do that. So this transcends older or younger. There would be no discrimination against older people. I'm nervous about that in the United States. If we get a devastating epidemic, you know, you see these little op-ed things about how do we make a decision ethically who to save, right? Do we save that 21-year-old person who's not accomplished very much in their life and still may be an adolescent, and put to sleep the 75-year-old woman who's been a great mother, grandmother, teacher? How do you do that? Well, there's no good way to do it. I hope we don't come to it. This country should have enough resources and ingenuity to make the respirators we need and things so we can offer the best to everybody. I'd hate to see those decisions because there's never a right answer. It's so context dependent, right?
Right.
And although older people may not have the same reasons for wanting to have a long life expectancy as younger people, you know, younger people want to see their kids grow and, you know, their families thrive, their significant others do well. Older people may want to see their grandkids and have, you know, and reunite with their friends. But these are such subjective feelings and perceptions for all of us that there's no way of making an appropriate decision for all.
Absolutely.
So I hope we don't get there. That would be, you know, that's like a Sophie's Choice thing. I hope we don't get there.
Sure, sure. Yeah, luckily it looks like we're reaching the peak, and hopefully we're going to start going in the right direction soon. So you did talk about you know, the role of telemedicine and how that's changing, and how maybe the role of, you know, personal one-on-one you know, appointments are going to maybe start to go to the wayside, especially, you know, during these times. What do you think about the role of telemedicine after all of this subsides? And, you know, do you think that it's going to start being implemented more even when there isn't a pandemic to kind of deal with?
Yeah, that's a great question. I think telemedicine is good when you're seeing people face to face, but there's nothing to me like a regular face to face visit. And of course, you have to examine patients. But after that, you could do a lot with telemedicine. It's been here, but it's never taken off. There have been all issues in who pays, you know, is Blue Cross Blue Shield, how much are they going to pay? You know, is a phone visit is not as good as a video visit. and really getting the equipment to work en masse. I mean, it's one thing if you have a small volume. I have a great friend who did telemedicine 20 years ago as a psychiatrist um, for rural Vermont. And you know, uh, ironically, all the new smartphones and things have made it so much easier, right? But the platforms will have to be adapted for medical institutions, for safety reasons, et cetera. I think it's going to be here. Ironically, it's going to cut a lot of costs because there won't be facilities fees, and you won't need as much staff. And I suspect it's not going to dramatically affect outcomes in a lot of people. So I think this unfortunate pandemic is going to change a lot of healthcare and maybe make it more cost effective and for the wiser, because you won't need physical buildings with people in it and huge staffs. A lot can be done without it. Schedulers, IT people who set it up, and I think all of that can be done already. That will be a problem for older people, because older people, I had to work with our neighbors. We live in a planned community, not a retired community. And a lot of our neighbors are older, and I just showed my neighbor how to set up her Zoom calls. And it's just what comes for a millennial in 5 minutes, is going to be harder for the older people to adapt, but it can be done. We sometimes make it harder than it is. And the grandkids, the kids, the next door neighbors who are facile can teach mom how to use the cell phone, how to turn on the camera. Most of them know how to do FaceTime with their grandchildren. We have mastered that a long time ago. And so I think it's going to work and change a lot of medicine and maybe make it better. But it may financially change the model. It may financially change the model very much. When you see a patient, in a hospital, you get an RVU. Are you familiar with that? You're paid on, well, the pay system includes your facility, your work, and everything. And, where the philosophy of current culture is to do more with less, especially in medicine, all these great things we have, but less time. Maybe this is going to transcend that and make it a little bit better, but it's going to change the financial model, and it's going to require some stepping up the technology that a lot of hospitals and docs don't have the best experience with to make it work for the patients. But I think it's here to stay, and I think it's going to change things. Patient's going to say, look, I saw Muss on the phone. He looked good. I had my mammogram, it's fine. I'm doing well with my pills. Why do I have to go to UNC, pay a facilities fee, pay for parking, gas? I'll call him in 6 months, see how he's doing. I think it's coming.
Yeah.
What do you hear from others? I'm curious.
Kind of a similar, across the board, it seems to be about the same. I haven't heard anything about the potential to save money. So that's a really interesting point, and one that, if that's the way that we're going to go and it's easier for patients, then why not, right?
Yeah, just think you could buy an accurate blood pressure machine, your pulse ox. I had a patient, she's a young woman with bad COPD. She got sick. I was worried about COVID. I had her tested, but she's went out and bought her own pulse ox, started measuring it. It's going to require a different kind of support, but I think it's here. And when you just think of the savings for patients, be bad for hospitals, probably bad for docs, but very good for the public. And so I think it's going to happen. I think you, as a much younger person than me, would you be comfortable talking with most of your docs, like this?
It would definitely be
you don't not answering for yourself, but you and your friends, would you be comfortable?
Yeah, it would. I mean, I think that's kind of the way of at least our world. So yeah, why not, right?
Right.
You know, I think that the face-to-face is still definitely necessary, but if you get your physical exam and it's going, you know, it seems fine, then I think that
Right.
checkups can definitely, and I heard from another doctor that it really saves the patients who may be elderly, it saves them that trip into the city that they don't want to make to
Sure.
begin with, and it also can help the caregivers from, you know, having to take off work or something like that.
Those are excellent points. Those are excellent points. I mean, coming into UNC Chapel Hill is intimidating for a lot of older people, especially rural people. Our parking lot is one of these things you drive around in a huge spiral. The spaces are tight so they can fit everybody in there. Then you have to take a little shuttle into the hospital, and then we bill people. So even though that's one of our major complaints, and many of us say it's crazy, um, it's a great point. And then the caregivers as well, it'd be a great point. And I'd be very comfortable with people who don't need to be examined, you know, who are doing well, uh, to do it on the phone. And let's face it, if it hasn't been done already, some very smart person is going to make a um, some type of device that can examine you at some point. You know, we know that you can. It's just going to happen, right? Some ultrasound that you'll put something on your body and it'll check your breasts and your liver and your heart. It's coming if
Oh,
it's not here already.
sure.
Some wearable.
Yeah, that's a good point. So I just have a couple more kind of follow-up questions. So we talked about the challenges that are currently for elderly patients. What challenges do you see, maybe with the exception of the potential for telemedicine and, you know, figuring out the system? What challenges remain, or, you know, looking to the future with elderly patients specifically? And, you know, do you think that COVID is going to become kind of an annual disease that's going to come around and require a little bit more maintenance for the elderly population?
I don't think COVID's going to become an annual disease. You know, I think the world has been slow on reacting to these SARS viruses with vaccines. You know, we had China, which is, you know, an incredibly gifted, huge country, but we don't know much about them. It's a totalitarian government. You know, you don't know what they're doing, but they've got great scientists and leaders there. You've had the Middle East respiratory you know, you've had H1. I think COVID lends itself very well to a virus. It doesn't change as much as the flu. And I would think that this is going to be an impetus to develop it, but it's going to take a while to do vaccine, and I think we'll have it. But I think that, you know, as people much more knowledgeable than I do, infectious diseases worldwide have been a concern. You know, we've lucked out with Ebola; it never got here. Um, some other terrible stuff. We've had chikungunya, we've had dengue fever. You know, we forget them. It passes over. We forget them. But I think we will have more attention to infectious diseases, better plans for the future. I think this is going to spur uh, medical centers, hopefully the CDC and other people to get more involved. I realize all the politics in this has been extremely complicated, but I think we will do it. And these vaccines will help older as well as younger people. But I think it's going to happen. I think the older people need to push for this because they're the ones who are paying the price in mortality rates. But the next greatest group, you know, is the 55 to 64, right? They're right below the 65 plus on all these charts. So I believe we will have it. We'll pay more attention to infectious disease. I mean, if you're a science fiction writer, you worry about the flu virus that gets really modified into something vicious, like in 2018, that comes from some, God knows where, Africa, you know, someplace from some bat or uh, God knows what, bird, and gets into us. But I think we'll be much more attentive, and that will help older people very much.
Great. And so what, you know, kind of as a takeaway, what advice do you have for physicians who are treating elderly patients among this crisis? And yeah, what kind of advice do you have, I guess?
So I would advise them to minimize their visits, do as much they can on the phone or with videos, only see or, have their partners or whatever their practice or hospital arrangements are, see the people who really need to be seen, to consider for new diagnosis, perhaps preoperative endocrine therapy when it's suitable for older people. It's going to be the majority of them. And then when I talk to them, I also feel it's very important. Older people need social support. And if you look at life expectancy and you look at two groups of older patients, people with poor social support, all other things being equal in their lives, their medical issues, etc., people with poor social support don't live as long. So when I called a patient, it seems like a decade ago, I'm losing time, but about a week ago, who I had just started chemotherapy, 71, she didn't want to visit her kids or got all these grandkids. She was afraid. I told her that she needed to learn how to do Zoom or Skype, and she needed to create a social network, and once a week, have a happy hour. And just do it with her friends for their support, because she can't be home with them all there. And this woman is getting treated here, but lives up in the mountains. But depending on your context, the social support is very, very important. So learn how to do one of the videos like we're doing, and do it once a week, and move your book club to a Zoom meeting, and maintain the same social contacts, because they're very important for your survival as an older patient, especially if you live alone and your caregiver is frequently a daughter, or not always, but or it's great if you have a spouse that's functional. My wife and I deliver groceries for some of our friends here around, but maintain that social support. So when the docs talk to the patients, instead of just the medical stuff and when your mammogram is and we can delay it, to make sure that they have the older things that are very important in assessing older people, like social support. Are they eating well? Not losing any weight, Mary, because, are you getting your meals on wheels? And all those other things that are important to older people. And I think that's very important in the conversation, other than just the cancer, and has a lot to do with how well they will get through this.
Yeah, very good points, and ones that I haven't heard often. So thank you for bringing those up. Is there anything else that I didn't ask you that you want to touch on, either with the pandemic, elderly patients, breast cancer, anything that you'd like to add?
No, I think that this is scary for all of us. There are times of uncertainty, but I have to believe there will be, we will learn a lot from this and make things better, for care in this country. So although I'm very nervous, and it's been devastating to some of my friends and patients, people in New York, and very close friends, I think in the end we will learn how to do a lot of things better. And so there'll be a little bit of an upside after a very bad downside.